So picking up with the next part of our nervous system 3 discussion, looking at dermatomes. So spinal nerves, how many pairs of spinal nerves do we have? Do you remember? 31 pairs of spinal nerves. So they come off of the spinal cord, not the brain. Those are cranial nerves. How many pairs of cranial nerves do we have? 12. Okay, so we have 31 pairs of spinal nerves coming off the spinal cord, and they innervate. They have a sensory portion, because remember, all spinal nerves are mixed. They have sensory information and motor information in those nerves. They're axons with 2-lane highways, right, going 2 directions. So spinal nerves have a sensory neuron, sensory axons that serve a portion of the skin. So these lines we see here in this diagram, these areas like here, we can see this says C5. So this is the cervical nerve number 5 serves this part of the skin. So if I have damage to the spinal cord or spinal nerve, cervical 5 spinal nerve, I'm going to have numbness or tingling on the surface of the skin if there's damage to that pathway. And this is a real easy way that when a person comes in with a motor vehicle accident to the ER, this is a real easy way for doctors to assess spinal cord damage or spinal nerve damage, is they can just test the surface of the skin. So if they feel the bottom of the foot, we're looking for lumbar nerve 4 or L5 nerve. And again, goes into that section of the spinal cord as well. There might be damage to that region of the spinal cord. So it's really interesting. I had a patient years ago in clinical that was telling me that she had damage to her L4, and that's why her calf, the front of her leg had numbness and tingling, and pain. So she needed more and more oxycodone, and it just seemed inappropriate by the way she was walking and talking that she was rating her pain at a 10, and she said it was down in the front of her leg because of this L4 damage. So I asked the doctor, he was on the unit, to come and talk to her. And he talked to her. She said, yeah, I have a lot of pain because of this L4 damage, and it hurts in my lower leg. And he said, well, where in the lower leg? Well, in the front. Every time I walk, I have a lot of sharp pain in the front of my leg. And he went out to the nurse's station, pulled up this map, and said, well, based on L4, it should be more the back of her leg and should be more here, right above the knee if it was truly L4. So based on that, and then some other things she was saying, he could see that her story was inconsistent, and therefore she didn't get the heavy-duty pain medicine she was looking for. They gave her something a little lighter, less addicting. And sometimes this is the interesting part about knowing your anatomy and physiology, is if you don't know your anatomy and physiology, and you have patients that don't know their anatomy and physiology, and they tell you a story that is inconsistent with anatomy and physiology, you're going to believe it and maybe give inappropriate care. I can't tell you how, and I can't think of an example right off the top of my head, but I can't tell you how many times someone will tell me something, oh, I have this and this because of this and this. And it's 100% inaccurate. It's impossible because of the anatomy and physiology that we know that they don't know, that the story they're telling you of why they need this medicine or why they had to have this procedure done, it doesn't measure up at all. But again, if you're a nurse who doesn't know the A&P, you're going to believe those stories and maybe, again, give a medicine inappropriately. So this is why we have to know our A&P. But not that you're going to know it all, right? Because you forget the details of any class you take. But keeping yourself educated and looking things up when you've heard of this, right? So in 5 years from now, someone's going to say, oh, dermatomes, let's assess dermatomes. You're going to be like, dermatomes, something with the skin. I know something about that. And then you're going to look it up on the computer and you're going to see this thing come up. And you're going to say, this is it. This is dermatomes. I remember this now, right? So keep in mind that you don't have to be an ace in A&P, but you have to pay attention enough that when you hear the word dermatomes, you know what to look for and you'll recognize it when you see it. Where if you never took this class and someone said dermatomes, you might think, sounds like something in music. Something, maybe I'm hitting a bell or something, right? So you wouldn't even know what to look for. But now, because you've taken A&P, derm, you're like, oh, derm is skin. I remember that. So this is important information to tell us about what's going on deeper by just looking at sensory supply to the skin. So this is all about, now the key word to highlight here is spinal nerves. It's sensory information coming or going to and from spinal nerves.
A while back, we had a guy get thrown from a bowl.
A what?
A guy get thrown from a bowl.
Oh my,
and
okay.
his neck. And it was pretty fascinating watching them. All they were doing was like rubbing a finger on his chest.
Exactly.
Our optics paralysis went.
Yeah.
I think it was his C5, or C4 or C5.
Yep, and that's right across the chest there.
He had no problem swallowing, but he couldn't feel anything like below his tongue.
Oh, okay. Yeah, so swallowing is a cranial nerve, and that's where in advanced A&P we really hit the cranial nerves really hard, and we assess the different cranial nerves. You have to memorize the cranial nerves and all about them. So like one of them is the optic nerve, right? So that's one of the cranial nerves we saw goes into the brain, right? And remember we had the optic nerve, optic tract, and then it goes to the occipital lobe. So you'll learn a lot about that in advanced A&P. So nervous system disorders that, affect us, some terms you should know. Hyperesthesia. Hyperesthesia means you have increased sensitivity to pain, pressure, or light. What would be hyperesthesia that some of you may have experienced yourselves or heard from family members, or if you've worked with patients? What are some examples of that? Migraines, perfect example. The way we would describe that is hyperesthesia to light, right? You don't like bright lights when you have a migraine. How about diabetic patients with type 1 or type 2 diabetes that haven't managed their diabetes and they have nerve damage to their skin? Have you ever had a patient scream out, "Don't touch my legs, you're hurting me," when you just touch their skin? Yeah, the neuropathy to those nerve endings in the skin, those nerve endings are damaged from high blood sugar levels over a long period of time, and they don't even let you touch them. And that's really difficult when you have a patient that needs to use a lift and lots of equipment and a system of 3 to 4 to get them from the bed to the chair because they're a bariatric patient, which means morbidly obese. Their skin is so sensitive they don't want you to touch them. But you have to touch them, right? Because they need to be turned, they need to be cared for. It's very difficult. Paresthesia is not necessarily increased pain per se, but it's that feeling you get when you sleep on your arm in the middle of the night and you wake up and it's tingling. It can be burning. That's painful, right? We call that paresthesia. That means there's some damage, but the nerves are trying to make sense of the information, but there's maybe lack of oxygen or damaged nerve endings, and that's when people get that tingling, prickling feeling. Exactly. And another example, I was in a clinical, and a lot of my clinical experiences are in multiple hospitals during my nursing program here at Western. So it's going to be amazing. You're going to have so many stories to tell just as you go through the nursing program because they put you in so many different environments. It's really, really interesting. I got to see a lot of really neat stuff here at Western. And not all the colleges can do that, actually. Western is one of the better colleges of all the colleges in our area for putting you in really good front row seats with patients. Like I got to work directly with a patient who struggles with schizophrenia, where some of the other colleges you get to just observe patients from a distance with mental health disorders. We got to actually be assigned a patient one-on-one, give them their medicines, talk to them, learn about what it is like to live with some of these mental diseases. So it was interesting. So this was another one. I got to follow a patient pre-op before his knee replacement. I got to watch his knee replacement. Then I got to follow him back to his room after his knee replacement. That was really cool to see everything that patient experienced, because when you're in nursing or any healthcare setting, if you're going into surg tech or radiography, you only see that one part of that patient's day, right? You don't know where they've been, where they're going. So it's really interesting to do that. And this guy, his feet were really cracked, and he had uncontrolled diabetes, and the surgeon told me in the surgical suite, he showed me his x-ray and said, this is how bad these guys' knees are. It's bone on bone, lifetime of obesity, lifetime of uncontrolled diabetes. So this guy is really at risk of this knee replacement going bad because of the high sugar environment, artificial parts, increased chance for infection due to poor blood flow because of damaged capillaries to this knee. He's at risk. And if you've gone to the nursing homes, there's people that have below the knee amputation. Some of those are knee replacements that didn't end well because of uncontrolled diabetes. So he said this guy is hugely at risk because of his failure to control his blood sugars. So when he came out of out of the surgery, went back to his room with him. He was awake and, you know, hanging out, and his wife was there. And I said, boy, your feet look really cracked. I said, it's really, really important you keep lotion on your feet, because if you get a crack and an injury on the bottom of your foot because of your diabetes, that could lead to a serious infection. I said, do you have any numbness at all on the bottom of your feet yet? He said, no, just tingling. I'm good. I'm like, oh, no, that's not good. That's an early sign of nerve damage that's going to lead to numbness if you don't control your blood sugar. And that's the biggest reason, you know, we see people in the hospital with these chronic conditions from diabetes is not controlling their blood sugars. And we got to teach every time they come in, even if they're 80 years old. You got to tell them again, are you controlling your blood sugars? You know, what are your levels? Because it does damage to these nerves, and they end up with these conditions. So neuralgia is just a sharp pain from inflammation to nerve. So when people have a pinched nerve, right? Back problems, neck problems, a pinched nerve causes a lot of pain. And nerve pain is very hard to control, very hard to control. There's one medicine we use, it's called gabapentin, that's pretty good, but it's not great. So people with nerve pain are really struggling. They need to go after the source of the nerve pain and get that fixed. Sciatica is when the sciatic nerve is damaged. Remember, that comes off the sacral plexus and goes down the back of the leg, the hamstring. So if a person is sitting a lot, that puts a lot of pressure on that nerve from sitting, and the bones that kind of change their alignment as we're sitting. So people have a lot of issues with sciatica if they have low back issues. So getting up, walking around is an important way to help with that. There's infections that are out there that infect neurons. So herpes type 1, herpes type 2, there's oral herpes, genital herpes. Herpes simplex 1 is oral, herpes simplex 2 is genital, and they affect the nerve leading to the skin. So when there's a crack on the surface, the virus enters from contact with another source that contains the herpes virus, and that could be on a pencil, it could be on a water bottle, it could be on your great Aunt Tilly's lips at Thanksgiving when you were 5 and she gave you a kiss and gave you the virus that way. So it's ubiquitous, which means it happens it's everywhere, and oral herpes is not a bad thing. It's just bad luck when people get oral herpes because it's everywhere. So it infects the neuron, lives down in the nerve ending, and then lays dormant there. And then when the body is stressed or ill, it tends to rise to the surface and cause a lesion. And that's a cold sore, right? So cold sores are due to a virus, and they are contagious. So if you or someone you know has a cold sore, you don't want to be sharing utensils, sharing straws and all that, kissing people that have an outbreak, because it spreads. And it spreads easily through broken skin. So when a person has chapped lips, that's a break in the skin, the virus enters that way. Herpes simplex type 2 is in the genital area, and that spreads through breaks in skin. So again, I don't know if I mentioned this before, maybe it was another class, but people don't usually flip on all the lights and do full body checks before they get together in an intimate way for intercourse, right? So good people get genital herpes as well. So doesn't mean a person is dirty or bad or had multiple sexual partners. It just means bad luck, right? But can we protect ourselves? For sure. You know, if you want to avoid bad luck, you do things that are a little smarter, and, you know, have conversations at least about, are you clear? Do you have any STDs that you're aware of? You know, and some people will even go as far as getting checked before, when they have a new relationship and they're going to go down that road together to be intimate, they get tested. And I think that's a really important thing to do, and to go to the doctor, get a physical, share the paperwork that you're both clear, then you both know. Because in today's society, not everybody is 100% honest or even aware. Somebody might be carrying a STD and not be aware of it. And this is a virus. So once a person gets this virus, there's no antibiotics to take it away. Would anybody know what the number 1 sexually transmitted disease is in the US? It's really popular in the high school. No? Chlamydia. Chlamydia is the number 1 STD as of right now, as of this date, 2019. But the good news is it can be treated with antibiotics and can go away permanently. So people just need to know they have it, for one, and to go be treated for it. And that's why we had that options in reproductive care. It changed its name, and I think it changed it back now. Everything comes full circle if you hang around long enough. But that would be a place for a young person to go that can get treatment low cost, because it protects the community when people treat their STDs. It protects the community too from getting it. So encourage, if you know somebody who has it, encourage them to get treated. But anyway, so this herpes can be spread from oral to genital, genital to oral. So when people are engaging in oral sex, they can transmit this disease. So it's not, you know, the virus prefers one area over the other, but it can cross over. So again, it's important to know who a person is with to prevent the spread. And if a woman who's pregnant has genital herpes, the immune system is suppressed when a woman is pregnant. So women are more likely to get colds and flus when they're pregnant because the body suppresses the immune system because there's half of a little being in there that's not part of that woman, right? It's the man. So the immune system is a little bit suppressed. So because of that, if she has genital or oral herpes, she's more likely to have an outbreak during her pregnancy. So if that outbreak happens right prior to delivery, baby cannot pass through that area because it can pick up herpes by passing through, and that can be very harmful to a newborn. So they're going to do a C-section if a person has a genital herpes outbreak. So it's really important that people tell their doctors if they have genital herpes so they can take the necessary precautions. And again, it doesn't make someone a horrible, rotten person if they have these conditions because it's out there. Shingles or herpes zoster is the adult version of chickenpox. So people that have had chickenpox in the past, sometimes it can resurface as shingles. And it is common in people that are immunosuppressed. So people that are getting chemotherapy can end up having shingles. So what does that mean? If a person is pregnant and is taking care of a patient that has shingles, which happened to me, I didn't find out that the patient had shingles until the second day I was taking care of them. And I was pregnant with my last child at the time. But I was fine and it was okay. But those are just, again, resurgences of that virus that kind of just lives in our neurons. Polio is a big problem in third world countries with poor sanitation. It's most commonly a GI problem. It causes diarrhea, but occasionally in some people it will live in the nerve endings and settle in the neurons and cause paralysis. And here, you know, you can see this boy has polio, and it will paralyze the neurons and will actually paralyze the neurons leading to the diaphragm, so a person can no longer control their respirations through the neurons. That's the phrenic nerve, right, that stimulates the diaphragm. So they had to put people in these chambers. This is back in the 1950s, I believe, in these chambers called the iron lung. And that's what that is. And it changes the pressures necessary for breathing to occur. So people had to just live in those things while they were fighting polio, and then eventually they recovered. So, but if it infects the neurons, you know, serving the lower leg, that's what causes paralysis and inability to walk and living in a wheelchair. And what president had polio? For President Roosevelt. But the good news is we went on a huge vaccination campaign worldwide. And the manufacturers of the polio vaccine brought the price way down so we could afford to vaccinate everybody. And we had huge vaccination drives. We had kids lined up, you know, across the country getting it at school, the oral vaccine. And we have almost eliminated it. It was down to like less than 1%. No, that was the number of, like I said, it's mostly in the GI tract. 1% goes into the neurons causing paralysis. But we had it almost virtually eliminated, but we can't reach everybody in the far reaches of these developing countries. So it's out there a little bit, but we've done a huge sweep across the world and almost eliminated it. But now, with the people that are against vaccinations and spreading bad information, we're starting to see a resurgence of some of these things. And we're even seeing cases of diseases that we had eradicated in the US. We're starting to see them crop up again because people don't want to vaccinate. So that's the end of the notes on the nerves, the peripheral nervous system. The special senses is the next set of notes, and this is something you're going to do independently and take that quiz separately, so that is not something I'm going to lecture on here. I want to move on to the autonomic nervous system. So I'm going to just kind of sweep through the special senses here and talk about our last little bit. The autonomic nervous system. Do you remember the things that we said are controlled by the autonomic nervous system? It's automatic, so things that we can't consciously control. 3 things. Smooth muscle, cardiac muscle, and glands. Very good. What's an example of smooth muscle that we cannot control? Nope. Cardiac muscle is not smooth muscle. That's why it's given its own category. So I would highlight these 2 things. These are the 2 key points that I want you to know for general A&P. These last 2 parts are extra information for advanced, but these first 2 things are what you need to know for general. So it's involuntary, cardiac muscle, smooth muscle, and glands. So smooth muscle, where do we see it? Yeah, the digestive tract. That's smooth muscle. So smooth muscle is any muscle that when it contracts, it lines a hollow organ or vessel and moves that substance along by contracting. So smooth muscle, we said the digestive tract. What else is controlled? Blood vessels, your blood pressure. What happens when smooth muscle relaxes? What happens to blood pressure? Someone else other than Nate. I appreciate your volunteering. So blood pressure, when I make it bigger, decreases, goes down. And then when I constrict blood vessels, blood pressure goes up, right? Okay, so that's why a person with narrowed blood vessels from a high cholesterol has higher blood pressure as well, and that's damaging for the heart. So the heart's trying to push against these narrow vessels until it eventually starts to fail. So lines the blood vessels, lines the GI tract. What else does it line? Where else do we find smooth muscle? Women, every month you have pain related to smooth muscle in this area, if you have pain every month. The guys know this too because they hear the women complain. What organ? Uterus. Yep, the uterus. And smooth muscle should not be underestimated. Smooth muscle can take a woman who's passed out on anesthesia, and that can squeeze that baby out without her partaking. Now, we know it's better that we not knock our moms out and actually have them participate in pushing that baby out by drawing up the legs and, pushing. But that baby can come out, with not as much involvement from the mother. Because how many people know of women who've had babies in the car and they couldn't keep the baby from coming because that smooth muscle was so intense. So smooth muscle is very strong and intense, and to push a baby through a narrow bony opening, definitely. Where else? Where else are we moving liquids through our body? Urine, yeah. The ureters that drain the kidney and lead to the bladder. So the ureters, the bladder, that is also smooth muscle. The reproductive tract, so the lining of the vaginal canal, the penile urethra, that's lined with smooth muscle, and that propels semen. It promotes movement of semen up the female reproductive tract. The contractions of smooth muscle in the vaginal canal and the uterine canal actually go in the opposite direction, and it's called reverse movement, reverse peristalsis. It moves it toward where the egg is going to be. So these all, the GI tract, blood vessels, uterus, ureters, bladder, urethra, those are all under involuntary control. They're lined with smooth muscle, and the autonomic nervous system is in charge. So cardiac muscle is muscle of the heart. That too is controlled by neurons that are part of the autonomic nervous system. So when you look at a typical nerve, remember it comes out through the ventral root for the motor response, right? So the response to the body. So if that neuron comes from the lateral horn of the spinal cord, it leaves the ventral root and it serves smooth muscle. Here's what smooth muscle looks like. It's a tapered, unstriated muscle cell. This is an example of a gland. What are some glands in the body that the autonomic nervous system would control? Just rattle off some glands that you're aware of, part of the endocrine system. Pituitary gland. That's the only gland we know of. Parathyroid gland. Sweat glands. The pancreas is a gland, so controlling blood sugar. What? Sebaceous oil glands. I'm not sure if that's really controlled by the nervous system particularly, because it doesn't really have a function. Tearing, yeah, that could be, because that's related to your emotions. When I'm thinking of the endocrine, I'm thinking of endocrine glands. I'm thinking of like the pancreas, the ovaries, testes, what? Adrenal gland, yeah. Ovaries, testes, even that is a little, it's controlled in other ways. But yeah, the adrenal gland is classically controlled by the autonomic nervous system. And we'll talk more about that. So the other type of motor division we have is the somatic. Remember, somatic means voluntary skeletal muscle. So if I'm throwing a ball, that's somatic. If I'm dilating the pupil, what is that? That's autonomic. So involuntary smooth muscle, cardiac muscle glands, autonomic. So if we look at functions then of the autonomic nervous system, it's controlling blood pressure because it's controlling smooth muscle, the blood vessels, controlling cardiac muscle, so the heart. It's controlling the breathing rate, so that is a little more, when we look at the medulla and the pons and those neurons coming out to control breathing, that's under autonomic control. Body temperature, so sweating, someone mentioned that, dilating the blood vessels near the surface of the skin. Digestion, metabolism, so metabolism, the thyroid gland is controlled by the autonomic nervous system. Certain hormones are part of the endocrine system, but the autonomic nervous system controls water, electrolytes. We'll talk more about that when we get to the end of the semester, but in advanced A&P. But our thirst center is part of the hypothalamus. Production of body fluids, talked about that, saliva, sweat, and tears, and then all these other urination, digestion. Defecation is bowel movement of the large intestines to have a bowel movement. So that's all autonomic. We don't have to think about these things, right? And thank goodness for that, because that's a lot of stuff. Keeps us going. So the hypothalamus is in charge of the autonomic nervous system. It controls those neurons. So the autonomic motor neuron starts at the lateral horn of the spinal cord and then comes out. There's two neurons. There's the preganglionic, then it stops, and then a new one picks up. Remember, a collection of cell bodies outside the nervous system is called a ganglion. So that's why we see that little swelling right next to the spinal cord. And then we have a postganglionic neuron. So there's two neurons that exit the spinal cord that finally reach that organ. So remember, the somatic nervous system leaves the ventral portion of the spinal cord here and then goes out and synapses on the muscle. So this is skeletal muscle coming out the ventral horn through the ventral root. This is leaving the lateral horn coming out the ventral root. Okay, so when we look at the two types of axons that are part of the autonomic nervous system, they're both coming through that ventral root, but only one is going to be more dominant than the other depending on what the conditions are of the body. So you have all these neurons coming out of the ventral root. You have somatic motor neurons. We have autonomic motor neurons, but some are dominating more than the other depending on what the condition is. So if I look at my ventral root, I've got, let's just focus on the autonomic neurons. We've got the parasympathetic neurons, and I've got the sympathetic neurons. So the parasympathetic neurons that are flowing out that ventral horn, or ventral root, sorry, not ventral horn, ventral root, are activated when the body is in a rest and digest state. So if I'm at a track meet and I'm going to run the 100-meter dash, are the parasympathetic neurons going to be stimulated or inhibited during that event? Inhibited, inhibited. So am I going to be digesting? Am I going to be moving urine, contracting the bladder? No. I'm going to suppress all those things because the body is in a fight or flight state to run that 100-meter dash effectively. So I'm going to stimulate those autonomic sympathetic neurons to go to those organs and gear them up for fight or flight. So if I'm sitting at home and I'm watching TV, am I in a sympathetic or parasympathetic state if I'm sitting home watching television? Parasympathetic. I'm in a rest and digest. So now I'm going to be digesting my food. I'm going to be feeling the urge to maybe have a bowel movement or feel the urge to urinate because I'm in a rest and digest state. So it just depends on what the conditions are of the body. And these neurons exit the spinal cord at different locations. The sympathetic neurons exit in the thoracic and lumbar regions of the spinal cord, and the rest and digest exits via the brain and the sacral region of the spinal cord. So if we look at any organ, let's look at the smooth muscle of the eye, the iris. So the iris contracts to make the pupil smaller, or it relaxes to make the pupil bigger. So which would we want in a rest and digest state? Well, let's turn it the other way around. Let's say I'm in a fight or flight state. I want to fight a bear. Do I want to bring more light in for better vision, so dilate, or do I want to constrict because light doesn't matter? I want to dilate, yeah. So the neurons that are serving the iris, there's two types. There's the parasympathetic and there's the sympathetic. We call that dual innervation, which means both neurons are there, but one of them is going to be more active than the other depending on what the state is at the time. And the hypothalamus is what is determining what that state is, because the hypothalamus is boss. So the hypothalamus decides, okay, we're in a fight or flight. The body, the eyes, the vision, just the optic nerve just brought information that there's a bear coming. So therefore, we're going to dilate the pupil to make sure we can get good vision to fight that bear. The parasympathetic neurons will be inhibited so they don't constrict the eye. What's going to happen to the heart, the neurons serving the heart muscle? Are we going to speed up the heart rate or slow the heart rate? Speed it up so we can pump more blood to the, what about the blood vessels serving the muscles? Are they going to dilate or constrict? We want more blood flow to muscles or less blood flow? More blood flow. How about blood flow to the digestive tract? Do we want to stimulate or inhibit those neurons to the digestive tract? Inhibit, right? So we're going to stop slow smooth muscle contraction to the digestive tract. So we're going to inhibit the parasympathetic neurons that want to rest and digest, right? Because what happens when a person gets really upset, the sympathetic gets some really bad news, and they get really upset, how does their stomach feel? Nauseous. And that's because smooth muscle contraction in the digestive tract has stopped or slowed significantly because the sympathetic nervous system is dominating and those neurons, those parasympathetic neurons, are being inhibited. So people feel instantly nauseous because of poor blood flow. So do you want to be feeding people that just came out of surgery and maybe their smooth muscle isn't awake yet from the anesthesia? Never. We always start them out with small sips of water. And if that goes well, then we give them some clear liquids, like maybe some Jell-O or some apple juice or some Sprite. And if that goes well, then you advance the diet as tolerated, we call that. Because when the smooth muscle is not working in the digestive tract, we feel nauseous. How do people feel when they've just ran a race and they had something to eat, like kids, you know, oh, I got to run this cross-country meet, I'm going to have a sandwich before I get there. What happens at the end of the race? Some of them are going to throw up that sandwich, right? Because it's not digesting, because blood flow is being diverted to the muscles to run and effectively, you know, win the race, or again, it's in a fight or flight situation. So the parasympathetic nervous system, 90% of the neurons that are controlled through the parasympathetic nervous system run through the vagus nerve. So the vagus nerve is boss of the rest and digest autonomic division. So it stimulates smooth muscle and gland when we're in a rest and digest state. We can stimulate the vagus nerve. There's a special way that we can stimulate the vagus nerve. And do you know how that is? Some of you know it. I'm sure you do, Nate. Anybody know how to stimulate the vagus nerve? And you better be careful as a nurse, because you can indirectly encourage your patient to stimulate the vagus nerve, and they're going to fall off the toilet. And I've heard of one story where someone was discharging a patient. They were on the toilet. They were constipated. So what do you think they were doing in the bathroom because they were constipated? What? Pushing, right. They were pushing down. When we bear down, when we cough even, when you close that glottis in your throat and you bear down, you make the noise, that sound. If you do that really powerfully, like anybody would do reflexively during a bowel movement, but if a person is constipated, they're going to do it more. That stimulates the vagus nerve. And if we stimulate the vagus nerve, that stimulates the parasympathetic neurons, which puts us in a rest and digest state. What happens to heart rate? It goes down. It goes down. So if a person has a really low heart rate because of heart failure and maybe some problems with the conduction pathway, and they bear down because of constipation on the toilet, their heart rate could go so low that they fall off the toilet, crack their skull, and die. And that has happened. So when we think about nursing interventions, like, oh, all I have to, like when I was in nursing school, I was like, are you serious? The only medicine I'm giving my patient today is a stool softener and Tylenol. I do more nursing interventions with my kids at home than I did on some days of clinical. But the funny thing about that is, that's really important. That stool softener, if that, let's say it just says PRN, which means as needed in the chart. What if I don't ask my patient, my heart patient with the bad heart and low heart rate and blood pressure, what if I don't ask them, did you move your bowels today? Because sometimes there can be 2, 3, 4 days can pass and nobody asked them that question. They're constipated, they're a little bit embarrassed about it, they don't want to talk about it. They don't tell you. So if you don't ask, they don't tell you, they go in the bathroom, they're bearing down, and they die from it. And that's, again, knowing your anatomy and physiology, knowing that if my patient is constipated and bears down, that could stimulate the vagus nerve and they could die from that. So I'm going to ask them, have you had a bowel movement lately? No, I haven't. Oh, really? Yeah, and I'm really constipated. Oh, really? I can't tell you how many times I've asked, and then we just discovered it after 4 days of being in the hospital. Because people get busy. It's not anybody's fault directly, it's just people get busy. So you got to ask those questions, and then you give them stool softener and you tell them, you know, don't bear down when you're in the bathroom because that can drop your heart rate. I want you to be careful when you're in the bathroom now that you not bear down. Again, knowing your physiology, right? If I didn't know about the vagus nerve and I didn't remember anything from my class, I won't tell my patient that, and they can fall off the toilet and die. So vagus nerve. Another thing, I can save a patient or even a friend of mine on the basketball court. When would you want to use the vagal stimulation, the bearing down? This can save a person's life. I've used it myself. When I'm not in good shape and I was playing basketball on a women's league, all of a sudden my heart started beating out of control really fast, like brrr, not normal. And it felt really weird, and I corrected it in a second by doing what? Bearing down, but I didn't bear down. I coughed really good. Coughing is very similar to bearing down. So I just went like that. That's all it took. Boom, right back to normal again. Saved myself. I mean, what if I wouldn't have done that? Would it have stayed that way? Would I have passed out? Because when you have really high heart rates, your brain doesn't get enough oxygen and you pass out. What? Right, flip into VTAC and die and lay there waiting for an AED while everybody stands around and wonders what's going on. Yeah, and it worked with a patient too. We had an old man patient, you know, the phone goes off, we all go running down to the room and he's sitting there and his heart is going 150 beats a minute. Now that's okay for a short period of time, but if that continues, again, he's gonna pass out, die, we're gonna have a code, and he might die from that. It was an old man. And everybody's like, bear down, can you bear down? He doesn't know what that means. He's an old man, 85 years old, and everybody's yelling in the room, and I was just a CNA at the time, but I was teaching here. And I said, cough for us. And he goes, boom, right down on the monitor. Just a little cough was all it took. And right down his heart rate went, and he was fine. So it's not, you know, it's not amazing stuff that we do, but it's A&P every day that you're going to have an opportunity if you remember this stuff. So vagus nerve. What?
I've seen patients that had a third-degree heart block to begin with, vasovagal into a systolic, their heart
Yep,
stopped.
exactly.
They're bearing down,
Mm-hmm.
which
Yep.
Yeah, they can die in there.
Right, that's why I'm glad you mentioned that. That's why we need to stay with our patients in the bathroom. And we, as nurses, we're busy, right? And they're sitting in there and they have gas and they're a little constipated and we've got a ton of things that are going on and they need to sit in the bathroom for 10, 15 minutes and we're just outside the door. Are you done yet? Are you done yet? Well, if you're constipated and you're trying to get yourself in a rest and digest state, think of the patient. You're in a lot of pain, you just had bypass surgery, and then you can't breathe very well and you're coughing and now you're getting like the hiccups and you're just in a mess. And you sit down on the toilet and then the CNA is like, are you done yet? Are you done yet? Who can get in the rest and digest state to move the bowels if you just went through all of that to get to the toilet, right? So what do? Keep your patients, get their pain under control so they're relaxed. Be slow moving in the room. Don't be flying around the room showing everybody how busy you are because it stresses your patient out. I've done that. I've been like this, out in the hallway and then I go in the patient room and I'm like, hey, how's it going? And inside I'm totally stressed out. I have so many things to do. But when I get in there, okay, sure, yeah, can I give you that? It's called slow, purposeful movements. We just, really move slow. Don't stress your patients out. So vagus nerve, if their heart rate is out of control, have them cough. If their blood pressure is really low, tell them not to, do a lot of coughing. My mother had a vasovagal incident at the restaurant. She drank her water and had a little bit, sometimes it goes down the wrong pipe and you get that violent coughing reflex. She was coughing until she started to pass out a little bit and then came to. And my dad was across the table. He's like, what was that? What did you just do? She's like, what are you talking about? Well, you just like fell over and then sat up again. She's like, I don't know what you're talking about. She didn't even know that it happened because you lose, consciousness for a minute. So she ended up going to the hospital and spending the night on leads. And they said it was a vasovagal response. It just means that the vessels opened up. The vagus nerve was stimulated, so that opened up the vessels, slowed the heart, and she had a little bit of pause in her blood flow to the brain. Okay, so enough of that. So again, when we look at the neurons of the sympathetic and parasympathetic nervous system, here's the parasympathetic neurons. So they lead from the brain stem, most of them from the brain stem here, out to all these organs. So what is it going to do to these organs, these neurons, if it's part of the parasympathetic system? Speed them up or slow them down? Slow them down. Sacral region, it's going to speed them up or slow them down? It's parasympathetic. It's going to slow them down, right? Okay, so if a person has a spinal cord injury in the sacral region, they're going to have a hard time emptying their bowels and emptying their bladder because that's the neurons for rest and digest. So sometimes we have spinal cord injury people that we need to manually stimulate the anal canal to get the bowels to move. So that's one of the uglier parts of nursing, but it's a necessary part because of the neurons that are here. There are people that have had, low back issues that have trouble emptying their bowel and bladder because that's where those parasympathetic neurons are located. Brainstem issues, luckily brainstem is so important that we usually die if we have brainstem damage, but that's what controls and causes the eyes to tear and us to have a watery saliva, slowing the heart, that's all. And look at the vagus nerve. So here's the vagus nerve coming off of the brainstem. Look at how it branches and all these important organs are controlled by that. And there's the heart, like we said. So if we stimulate it, it's going to slow the heart. Okay, sympathetic nervous system. So again, the key gland is the adrenal medulla. So when the hypothalamus is stimulated to say, we have a stress situation going on here, whether it's real or perceived, right? If you see a spider, a person that is a biologist that loves, spiders would be like, oh, cool, grab it. Excited, right? Or if a person has arachnophobia, it's going to stimulate the sympathetic nervous system. So it's going to inhibit smooth muscle and glands related to rest and digest. And there's neurons that go to the adrenal medulla to secrete epinephrine system-wide. So the adrenal medulla is a little gland on top of the kidney, right here, that releases epinephrine in a fight or flight situation. So again, the hypothalamus is going to be in charge of that stimulation, and that epinephrine is everywhere in the body. So is it going to take a while to calm down after a stressful event? Do we want to take a blood pressure when someone has a coughing fit and their eyes are going to pop out of their head because they're in such pain from having their chest cracked from bypass surgery? We want to take a blood pressure? No, not if we're trying to get an accurate blood pressure. We want to make sure the patient is not stressed out. So you want to have them sitting, relaxing for about a half an hour, then take their blood pressure. So that's the adrenal medulla. It's the central portion of this gland. The middle part is the medulla, and that secretes epinephrine to the blood. So it takes a while for someone to recover from a stressful event because the body has to break down epinephrine and get back into that rest and digest state. So it's a little longer acting when we're in that. So this compares the two. So here are neurons coming off the brain and the sacral region. These are parasympathetic. And the sympathetic nervous system comes off the thoracic and the lumbar region of the spinal cord. So these neurons come off here. They synapse. They connect with another neuron inside this ganglion, and they continue out. So again, if there's damage to the thoracic or lumbar region of the spinal cord, that's when you're going to see problems with the fight or flight response because of the location of the neurons being there. So notice, though, that the organs, most of the organs are shared, right? So again, dual innervation. So I have the iris is dually innervated. It has parasympathetic neurons to constrict the pupil. It has sympathetic neurons to dilate the pupil. So you can kind of go through this list and see how these would all contribute to rest and digest. Contracting the bladder, that's a rest and digest thing. When we think of the parasympathetic nervous system, think of it as a wet system. Tearing, peeing, secreting enzymes, those are all things that promote a restful state. So when you're racing around with your kids trying to pack up and get ready for a vacation, and you jump in the car and you get on the interstate and everybody's, we're on our way. And then the proverbial request from the back seat comes, I have to go to the bathroom. What? We just got in the car. We just got on the interstate. Why didn't you do that at home? Because everybody was running around, packing, yelling, getting ready. That's how it is at our house with 6 kids when they were younger. They didn't notice that the bladder wasn't contracting and sending that reflex that they had to pee because you're in a stressed state. Maybe you've done it yourself. You're running late for work. Oh my gosh, I gotta do this, gotta do that, get the dog out, go for work, and get in the car. Oh my gosh, I forgot I need to go to the bathroom. Now you got this long drive, right? So that's part of the autonomic nervous system. We have reflexes the same way as we do with our muscles. If I shine a pupil in the eye, it automatically constricts because of this not an interneuron, but this jumping over to the other side. So we do have reflex with autonomic neurons as we do with somatic neurons. So we'll pick up next time